Okay, well, thanks for having me, Sal. I appreciate it. And that last question for the panel was actually very timely, particularly for, I think, community docs. One of the reasons I really enjoy AEM as an organization, they really push to think about what is the experience of a community physician and how do we actually make things better for those folks, rather than this sort of academic world where it's very easy for us to sort of assume that everyone has all these tools to them. So during this talk, I'm hoping to sort of make point of care ultrasound a little more accessible. I would add this to that FAST list. Lung ultrasound by far is one of my favorite ultrasound modalities, mainly because it's so timely. When you're at the bedside and you're really struggling and you'd like to have more information for that really sick patient, this is that opportunity for you to use a diagnostic tool in your hand and really get to a better diagnosis or a more accurate diagnosis than you possibly could before the invention or the widespread implementation of point of care ultrasound. So without further ado, I do have to make a couple statements here. I am in the military, so these are my own statements and not of the US government. And I also have a disclosure. I have some intellectual property rights for some ultrasound technology, which shouldn't affect this talk. So we'll move on from there. So in this talk, we're gonna really talk about how point of care ultrasound can be used in COVID patients. And at the end of the day, what you're going to really find out is it really boils down to lung ultrasound. There are a couple other modalities that are being used, but really for the end user who is working day in and day out in a community setting, this is the one tool that really extends beyond COVID and really before COVID. As I mentioned before, this is my favorite modality. So let's start off with a case. So you're working a late night shift. You're at your workstation and they sort of roll by a guy in a wheelchair who looks like he's clearly dyspneic. He's reportedly had a fever. And of course, he decided to ignore the COVID restrictions and went to a bed and breakfast during the COVID pandemic a week prior, and is now coming in really short of breath. Now, even before the pandemic, when you saw these sort of patients roll by you, if you're anything like me, I would typically start thinking about, all right, well, I need to get oxygen. I need to get my safety net. Where are the nurses? Are they going to be coming in to help out? Maybe call for BiPAP, maybe get an x-ray. And really from there, prior to ultrasound, what you'd really do is often throw the kitchen sink at them. You might listen to their lungs a little bit. You might get a little bit of their history. If they're a smoker, if they have CHF, it's really a wash, especially once you add the fever in there. And so it gets really challenging. And this is where ultrasound really shines, and even more so during the COVID pandemic. So what are the uses that have been implemented for point of care ultrasound? Well, you know, if you really sort of think about the patients you've been seeing the past 15 or 16 months, the ones that really get admitted, the ones that are the sickest of the sick, tend to have some sort of cardiopulmonary problem. And so really that's where ultrasound shines in this case as well. Now, there is some thought that there's increased thromboembolic events. And so you'll also see a number of case reports and case series that discuss DVT. But for the purposes of this talk, we're really going to focus on lung ultrasound. And then we'll talk a second about some cardiac ultrasound that may be applicable as well. Now, I fully appreciate not everyone trained in the area of ultrasound as a widespread modality as a resident. And so I thought I'd talk about a few of the basics. So if you haven't done a ton of lung ultrasound, if you have done any, you might have done some for a pneumothorax, and you might be used to using a linear transducer or a high frequency probe. More specifically for the undifferentiated acutely dyspneic patient, what you really want to do is grab that phased array or cardiac probe, something with a low frequency. Now, if you don't have this little stubby probe and you have that more broader sort of curvilinear probe, that's totally fine. As long as it's a low frequency probe, that should do you just fine for the purposes of lung ultrasound. So once you find the right probe, what you want to do is apply the probe to the patient, of course. And there are many protocols that are described in the literature, and they all boil down to basically looking at 2 or 3 or 4 windows in the anterior or mid-axillary line, and then taking that probe and looking posteriorly as well. And here's an example of what it looks like sort of from the research side of things. They sort of have these little zones that they've identified and so on and so forth. But the reality is, in day-to-day practice, when I see that acutely dyspneic patient roll by me, even before I get my stethoscope, I probably have that ultrasound probe on them, a lot like you see in this image. And so I take that probe, I put it on their back, sort of in their posterior side. I look for a liver, a spleen, a kidney, something that I recognize, and then I move that probe superiorly towards their shoulder blades. And I really do that on both sides, really looking for pathology, as we'll show you in just a second here. So if you've never really done this before, what you should see is some sort of soft tissue echoes. They tend to be hypoechoic in nature. The next thing that you sort of want to identify are essentially ribs and rib shadows. The ribs, because they're so dense, are going to create a dark shadow below them. And then the most important landmark for you to really look at is really where the pleural line is which is just below that rib shadow. And everything below that, just for your sake of memory and for learning, everything below that is really just artifact. And you'll see there's some amazing artifacts that you can see that help inform what you're looking at. Occasionally, if you have like fluid or really dense pneumonia, you'll see stuff beyond the pleura. But a lot of the things that you're seeing that I'll show you in a second are really just artifacts generated at that pleural line. So as a review, here's a couple of the key terms you'll need to know before we go over the COVID findings. The first one being A-lines. A-lines are essentially a horizontal reverberation artifact. It represents aerated lung. It's these sort of white lines you're seeing. If you see that, it basically means aerated lung. There could be a pneumothorax potentially, but generally there's no fluid there. There's going to be no interstitial fluid. There's probably no pneumonia directly abutting the pleural interface. In contrast, B lines are vertical reverberation artifact, and these typically suggest interstitial fluid. Now, prior to COVID, you would generally say if you saw these everywhere, that's just pulmonary edema. Certainly COVID has really changed the way we think about pulmonary or lung ultrasound. And so we'll talk about more of that in just a second. The other term you might have commonly heard if you're sort of in academics, or even if you're not and you've just picked up an article, or if you trained maybe 10 or 15 years ago like I did, you'll hear the term comet tail artifact. Comet tails are still used. It's sort of a more generic term and it's not specific enough. Really, when people say comet tails, it could mean the B lines or these little thin lines you see in the upper right coming off the pleural when maybe you're looking for a pneumothorax. Those more specifically are called Z lines. Not important for you to know other than that there is another term and another type of finding that we won't use specifically today. Consolidation, this is probably my favorite part of lung ultrasound, is looking for pneumonias. I can tell you when I work in the community and you're trying to meet that sepsis bundle, antibiotics within 60 minutes and so on and so forth, I love seeing one of these acutely dyspneic patients. They come through the door, I put the probe on them, and within 30 seconds, I've diagnosed a pneumonia. I go out and order my antibiotics. And so from door to antibiotic order is basically 2 minutes. And it feels really good knowing that some administrator there is like admiring the fast way that I'm able to implement their sepsis bundle for them. Now, how do you identify consolidation? Well, consolidation is basically, in the traditional sense, part of COVID really is just the pus in the lung from a pneumonia. It's sort of filling all the little bronchioles, all the alveoli, and it's basically turning aerated lung tissue, which you normally cannot see, into a solid mass. And so it becomes so solid, it starts to take on the look of liver. And so the term hepatization has been coined. Now that's sort of the most common, easy finding you'll see that will key you into the fact that you're looking at consolidation. You do have to be careful, as I mentioned before, you do want to make sure that you've identified the liver and spleen before you sort of call something, because I've seen a number of residents that have told me that they found a pneumonia only to demonstrate to them that that's actually just their liver or spleen. So once you've identified this, the next thing you want to look for are air bronchograms. You're going to see these little white lines or little white specks within the consolidated tissue. That is basically the air bronchogram you see on a chest x-ray. It's little pockets of air within the bronchioles, sometimes within the alveoli, and it creates this bright white artifact there. And so those are air bronchograms. The next thing you'll see is the shred sign, which is basically the interface between consolidated pus-filled lung and normal aerated lung. And so because where that pus goes is very irregular, it creates this really shredded looking appearance to the lung. And then because there's inflammation and fluid and edema around that pneumonia, you're going to see B lines essentially, or comet tail artifact, coming off of the consolidation. So those are the basics. That should get you through the next 5 or 10 slides of what you're going to see with lung ultrasound in a COVID patient. So how's it being used? Well, over the past year, really, there's been an explosion of literature, really in all aspects of COVID, and particularly with lung ultrasound and just point of care ultrasound. I've really been watching a lot of this. There's probably no less than 500 or 600 or even 1,000 articles that will come out if you just type in COVID and ultrasound. And so they're used in lots of different areas. More specifically, what I tend to use it for is the rapid assessment. As I told you, when I'm working and you're crushing through patients, the last thing you want to do is sit there spending 20 or 30 minutes getting information that's not going to help you right now, right? And so really at the bedside, I'm making this rapid assessment. Why are they dyspneic? Is it CHF? Is it a pneumonia? Is it even COVID, especially now that we're in this pandemic? But there are these other reasons you might want to do point of care ultrasound, specifically lung ultrasound. You can certainly use it to track and trend disease progression. And I suppose if you work in an ICU, this would be much more relevant to you. So here are the findings that have been identified most commonly with COVID and lung ultrasound. You're going to see things like a thickened pleural line, B lines, different variations, whether you might see a few, you might see some that are multifocal, you might see some that are confluent and combined. You'll also see things that look like mini pneumonias or tiny little consolidations under the pleural surface. Sometimes you'll see effusions. And really what you can do is you take all these findings, and generally the take-home message of this entire talk is the fewer findings you have, the least bad their pneumonia or their COVID lung is, the more findings you have, typically it's going to be much more severe disease. And so that's the take-home. And I'll show you sort of the variations of what that looks like in the subsequent slides. So here's pleural thickening. On the right side, on the left side, you'll see fairly normal lung. You see the pleural line sliding back and forth. It's very thin. That's what you'd expect in essentially normal lung tissue. On the right, on this COVID patient, what you're seeing is there's lots of inflammation. The lung is inflamed, the pleura is inflamed, there's a lot of edema. And so now you see this thickening of that pleural line right there. And that irregularity is basically one of the first signs you might see before you see tons of B lines everywhere. Now, B lines, like I said, prior to COVID, really were synonymous with pulmonary edema. Now, you could sometimes see it around pneumonias, as we mentioned before on the consolidation slide. You'll sometimes see it in pulmonary contusions, maybe atelectasis, maybe just you gave them 4 liters of fluid because you thought they were dehydrated, and for some reason, you then decided to do an ultrasound. But really, the way we look at B lines has changed quite a bit since the pandemic came out. And so the key differences between what you would expect to see maybe in your prior training with B lines and pulmonary edema, for that, you'll see B lines everywhere. You know, as you'd expect, pulmonary edema is very rarely focal. But, you know, when they have like fulminant cardiogenic pulmonary edema, they're going to have B lines everywhere. Whereas in COVID, unless their disease is exceptionally severe, literally where you've probably already intubated them, usually it's going to be very patchy. You're going to have areas of sort of B lines, you're going to have areas of normal lung, and you're going to have these pleural irregularities where you see sort of the pleura looks thickened or maybe kind of lumpy and bumpy. On the left side image, you'll see the pleura is still quite thin. And so that would be more consistent with just standard B lines versus the right side is more of a COVID lung where you're seeing the thickening of the pleural lines as well as some B lines shooting down. As the disease progresses, you'll start to see some of these B lines coalesce into sort of less distinct but broader. And then you'll see them even get more kind of consolidated into what is called light beaming, where you'll see these broad beams of essentially a big B line and a bunch of them combined together, interspersed with normal lung that just comes across as you scan through the back. The other sort of key finding that you'll see with the COVID, which you've sometimes seen some pediatric pulmonary processes with lung ultrasound, but this one is also frequently seen in COVID, are these subpleural consolidations. What you're seeing here is this sort of looks like a mini pneumonia, and it's sort of sliding back and forth along the pleural line. And that is fairly characteristic of COVID. When COVID gets really bad or you have a secondary pneumonia, what you'll see is a big consolidation. On the right side of this image, you're seeing the liver. Then you'll see sort of a bright white curvilinear line. That's the diaphragm. And to the left side, you're seeing what looks like liver again, but you'll see those little bright white lines or speckles in them, and that's the air bronchograms that gives away that it's a consolidation. Finally, you'll see pleural effusions. They're not very big. Usually they're pretty small, and they tend to be just sort of along the pleural interface. So if you see this, this is another common finding within COVID. Now, that was a lot of findings to go over. And here's a table sort of summarizing the types of things you'll see with mild to moderate and severe lung disease. I've sort of highlighted them to sort of show you the difference. And as I mentioned before, the less frequent you find something, the more likely it's minor disease. So this is a mild to moderate chest X-ray. And so it's going to be along that right column where you have some focal sort of areas of irregular pleura. If some of those consolidations have not reached the pleural surface, you may not see them. And then as you get to more severe disease, really bad COVID lung, on the left, you're going to see lots of consolidations. You might see some pleural fusions. You're going to see B lines everywhere, and maybe some of that light beaming. The last thing I'll sort of mention, which I think goes hand in hand with some of these really sick COVID patients that you might see, not only are they going to have a pulmonary problem, often they might have a cardiac problem. And so inevitably, when people come in with shortness of breath, you always have to think heart as well. And as Sal was mentioning, pericardial effusion certainly could be a possibility, but myocarditis is certainly something we're seeing more and more, particularly with this younger population of folks that are getting COVID and probably taking up a higher proportion of the COVID patients coming in hospitals these days. So what does that look like? Well, it actually doesn't look much different than you might see with myocarditis and any other cause, whether it's idiopathic or any other type of viral myocarditis. What you might see is a dilated heart, as in this picture. You might see not great contractility. And so there are some studies that suggest myocarditis in some variation of the ICU COVID patients is actually pretty high. But I think obviously the research is still need to be completed to really get that true correlation. So let's go back to our case. You have that 58-year-old male, he rolls by you, you bring your ultrasound over to the bedside. Even before you pick up your stethoscope, sometimes I leave it in my bag and I just run to the patient, and you have that ultrasound, you put it on their back, and you see this. Right away, what I'm seeing is I see some thickened pleural lines. I see some B lines, some of them confluent. On the right, I'm seeing some subpleural consolidations. And based on their story, I have a pretty good indicator that this is probably going to be a COVID case, even before that rapid antigen test comes back. You go through the normal motions. And so this person has really helped me triage. And instead of throwing maybe Lasix or nebulizers at this patient, I've really sort of directed the right therapy. And of course, this patient will probably be admitted if they're hypoxemic. They'll probably get some steroids and some antivirals, and the rest is history from there. So in summary, lung ultrasound really is a great modality in evaluating COVID patients. It really helps you sort of differentiate that dyspneic patient. You're still seeing CHF, you're still seeing COPD, but now you have this additional diagnosis that can really be readily determined just with a simple ultrasound device that you bring to the bedside. You can scan them any way you want. Like I said, I keep it really simple. And as I mentioned before, the more severe the disease, the more likely you are to see a lot of these findings in combination. And with that being said, that's my talk. Here are my resources. And if you have any questions, please feel free to email Sal and the Rebellion team, or you can email me here and I'm happy to answer them after the fact. Thank you for your attention.